Hello, I'm Lynn White and I'm very pleased to be here today to talk to you about extended depth of focus contact lens designs and how to optimize their performance to give your patients the best vision possible. First of all, I'm going to talk about depth of field effects, because this is what happens when we shorten or extend the depth of focus at the retinal level. So a shallow depth of field shows you that you've got an object in focus and everything in front and behind of it is out of focus. Not that your brain really notices that. In a natural environment, all you're aware of is an object is clear. If we extend the depth of focus at the retina, we extend the depth of field that we're viewing over. So like this boardwalk, we see multiple objects equally in focus at the same time. And this is the type of trick we're trying to play on the eye to get them to see over longer distances for presbyopia. So what happens at the retina level? Well, when you're looking into the distance at an object and everything else is blurred out, all of that energy from that object is falling on the retina and gives you the rich detail at that one point. If we stretch out that packet of light to give you an extended depth of field over a longer distance, you are actually spreading the energy out, the same energy out over a longer distance. And although that actually in effect reduces the clarity of the objects over that distance, your eye doesn't perceive that. It just perceives everything as being equally clear, as in on this boardwalk. So how do we achieve that in the eye? Well, the majority of the work is done by the pupil. It dilates and constricts in response to light level and accommodation. And it's helped out by the natural spherical and chromatic aberration from both surfaces of the cornea and both surfaces of the ocular lens. So if you have a small pupil, it extends the depth of focus here, extending the depth of field, giving you the boardwalk effect. If you have a short depth of focus with a wide pupil, then you get a smaller depth of field. And that's how the eye manages this. For contact lenses, for very many years now, we've had aspheric optic designs which manipulate the spherical aberration of the lens, which augments and enhances the eye's own spherical aberration to extend that depth of focus and thus the depth of field. These can work really, really well, but they have the disadvantage is if the eye's own natural aberrations are in the opposite direction, they can cancel out or even make it worse when you use aspheric optics, which is why for many years, there's a lot of arguments whether these even worked at all. More recently, we've had pinhole effect type extended depth of focus lenses, which are really a multifocal, a center distance multifocal with high ads, +4 or more, giving a blur in the periphery, creating an artificially small pupil, even if your own pupil is quite wide. So these work really, really well as a depth of focus effect. However, Brian Holden Vision Institute has brought out a different type of lens. It is not a multifocal, even though the optics somewhat resemble a concentric ring multifocal, they are not multifocal. They have a non-monotonic variable power profile across the optics, which acts in a completely different way to manipulate the higher order aberrations to extend the depth of focus of the eye and thus the depth of field. So they are not multifocal, they are not a pinhole effect. So at this point here, we'll just stop for a poll now to ask you, with your multifocal contact lens fitting, what issues do your patients report with multifocal contact lens wear? Glare, blurred distance at distance and near, ghosting at distance and near, or loss of stereopsis. Okay, so let's look at the benefits of extended depth of focus lenses compared to multifocals. Now, this is giving you an average multifocal design, an annular design, where you have one power in the center, be it center distance or center near, which goes through a transition intermediate area to the opposite power. So if it's center distance, this is reading. If it's center near, this is distance. And if you have a small pupil, you can see that the other annular area is cut out altogether. So you lose either your distance or your reading. If you have a large pupil, then all of those are simultaneously incorporated into the area, which can cause some confusion. But also you can, if your pupil's wide enough, get the carrier of the lens involved as well, which then can cause ghosting. Additionally, if your lens is decentered, you no longer have the optics of the lens lined up with the optics of the eye. And this often causes a great deal of problem when fitting multifocal lenses. However, when you have this variable power profile across the optic, in all of these situations, you're getting all of the power going through, the required power going through either a constricted or dilated pupil, or even when the lens is decentered, you're still getting the same effect. Not only does this minimize visual disturbance, but it helps to reduce chair time as well, because it works in all of these situations. You're not having to look at perhaps changing your lens, multifocal lens design, changing the fit, which often means changing brand because you've only got one base curve and diameter. So this really is the major benefit of going for this type of extended depth of focus lens. Now, when you have this type of variable power profile, you can change the power profile to make the equivalent of a low, mid and high type of lens for presbyopia. And as you can see here, if you've got a center near multifocal, as you increase power for higher levels of presbyopia, you're increasing the near and in the middle. When you do this for extended depth of focus lens, you're actually changing the design to stretch out those light packets over the area more over a lot larger distance. Now, if you want to look at some peer-reviewed journals on this, I recommend this article here in the Journal of Optometry. It's in two parts, where you're looking at the Edof lens design as designed by Brian Holden Vision Institute to two types of multifocals, a center-near multifocal and a concentric ring multifocal. Now, what these papers do are look at the patient experience of these types of lenses. And what they found was, from the overall vision satisfaction and the ocular comfort satisfaction, the Edof lens, the BHVI Edof lens, gave significantly better performance. And it's interesting to note that often ocular comfort is related to visual comfort. Obviously, there are some aspects of the material properties in here, but often when you're visually uncomfortable, you're also experiencing ocular discomfort. So the two are related. When you're looking at ghosting, although the performance was fairly similar in the distance in night and daylight, for intermediate and near, the BHVI Edof variable power profile gave significantly better performance at intermediate and near. So now we're going to go on to the fitting techniques. And one of the most important things here to understand is not to use a refractor head or phoropter head, but to use a trial frame. This is because phoropter heads tend to close in the visual environment and they affect the accommodative response. The trial frame gives you a much freer visual environment. Now, I'm repeating this again because it's extremely important to remember. Extended depth of focal lenses, apart from the pinhole effect one, are not multifocals. They do not work in the same way. And to emphasize again, this is the sort of effect of the retinal image quality of a multifocal, where you have a peak in one position, where with the extended depth of focus design we're talking about now, you have a much more spread out retinal image quality. And the reason I'm saying this is it's very tempting if you have a patient wearing multifocals just to go into your trial banks and pick up exactly the same powers in a different lens design. This never works, whatever you're fitting. You should always look at the guidelines supplied with the type of lens you're fitting. So what are those guidelines? First of all, before you even put a lens on eye or pick lenses out of the trial box, determine the dominant eye, establish the full correct spectacle refraction, not the one that you're modifying for your patient, just a full sight test correction. Determine the calculated best sphere, then look at that by testing it out. I'll talk about that more in a moment. And then choose your first Edof contact lenses based on the guidelines, which are 3 types based on range of spectacle add, up to 125, up to 175, that mid area, and then over for your higher types. And straightforwardly, low for the pre-presbyopes and early presbyopes, mid for your middle presbyopes, for your high presbyopes. The interesting part that's different from this to most multifocals is you put that high design in the dominant eye. Okay. So for looking at your dominant eye, if you use the sensory type, it's taking a 150 sphere and moving it across from eye to eye and finding out the situation in which the patient is most comfortable. If you end up with this, with the plus 150 in front of the right eye, this means the other eye is dominant, because this is the way the patient prefers. They don't like having the 150 in front of the dominant eye. The other way you can do check dominant eye is by doing that sort of thing, by creating a small hole, getting the patient to look at an object with both eyes open, and the eye that sights through it is the dominant eye. Often what happens if you do both, you'll find that you get a different dominant eye, depending on the methods. Always, I think, go with the sensory one because you're working with optics in a way. This is the one that you should be working at. It's the most useful in this situation. Okay, so establishing best sphere. Again, use your trial frame, put your phoropter head to one side. You want a natural visual experience. Put up the calculated best sphere, and I'll show you more about that in a moment. Then check that out for each eye and binocularly for distance and reading. It's important you spend time doing that now, rather than trying to do this when you've got different types of optics in the contact lens in the eye. Do it first, understand what makes your patient comfortable. So looking at calculating best sphere. Now, if you're in the situation at the top here, where you've got sills that can be easily divided by 2, it's fairly simple. So you halve it, add it on, and it gives you your best sphere. Okay. So in this case, you've halved it, you've got 0.75, you've halved that, you've got 125. The add is 225, right eye dominance. The recommended first choice would be 0.75 high, left 125 mid. If you're talking about sills that are not even in that way, and especially with myopes, you tend to go on the high side with myopes. So you assume your sill was 1 here, 150 here, halve and add on, which then gives you this best sphere. And then when you account for BVD, it will drop down. It adds 150, so it would be mid each eye. Experience tells us so far that you can always push the plus a little bit more on hypermetropes. For myopes, you need to make sure you're at the top level of the minus side. So when we're looking at market experience, and I know in Singapore you're mainly myopes, but if you do have hypermetropes, they generally will accept more plus. And this is often because a lot of them walk around without the glasses on. They're over accommodating a little bit, and they're not fully relaxed in accommodation. So you tend to be able to push that a little bit more over time. You can't do that with myopes. They need the maximum amount of myopic correction generally. So if you've now done your best sphere, you've got your lenses, you've got your trial lenses, you've put them in, send your patient out to sit before you do any kind of check-in. Let them adapt to the lenses in a natural environment. And go and see another patient, just let them sit out there. And in fact, what I tend to do is to get them trying on sunglasses or glasses, looking in mirrors, looking outside with sunglasses, looking around the room, which allows them to start adjusting to different distances without thinking about it. If I'm going to do a fraction, generally after that, I've seen the next patient, I'll pop out with flippers and just try them over the eyes when they're looking at things there or picking things up to read. If needs be, I'll adjust the contact lenses, leave them out there while I see another patient. All of this gets them adjusting without putting anything around near the face to induce accommodation. And that's how I find it works best. So once you've optimized your patient so far, it will take time to adapt to Edof optics. You're extending the depth of focus. You're giving them another different type of visual experience. You want them to understand that and get used to that experience in their own natural environment and with their own lifestyle. So that means any hobbies, driving, golfing, any long distance events they do, looking at the phone, looking at the watch, looking at tablets, reading in their own environment at home, which maybe have dimmer or lighter light than you have in your office. So you need them to go through that full range of experiences to make sure they're not going to take lenses away and then come back complaining a week later because it doesn't do X, Y, Z. Okay. Also, if you've got other designs or systems like multifocal and monovision, the brain has to wash all that out and get used to these type of optics. They are different from normal visual experiences. Also, if you're on a special word about monovision, if you have somebody, particularly with a high AD, one eye distance, one eye reading, you tend to have a lack of binocular crossover in intermediate, where it's either one or the other, and the brain tends to suppress the image it doesn't want to look at, especially if they're a very successful monovision wearer. When you're wearing extended depth of focus lenses of any type, what you tend to get is an area of binocularity, an overlap. So if you've got somebody who's got -350 in one eye, -4 in the other, you get an overlap, even if you're wearing it as more of a monovision type of lens, because the depth of focus is extended, you get more stereopsis. And what I will say is that for almost any other lens type at all, if you've had somebody in monovision and they've got suppression, it's very difficult to get them back into seeing binocular vision again. Okay, so now I'm just going to go through some case studies. These are actual cases of UK practitioners. They've actually tried the lenses out, they've reported back to us what they actually supplied in terms of revenue packs. And I'm using this to illustrate various aspects of fitting and fine-tuning lenses, not going to strict guide BHVI when you go beyond the BHVI guidance. And I apologise in advance, a lot of these are hypermetropes because we have a lot more in the UK than you do in Singapore. Now, in the first case, this is actually somebody who would probably be termed as emmetropic for most of their life. This is somebody with low plus, low stills, now got AB225, right eye dominant. They had been wearing Centenaire multifocals, and typically in multifocal wear, the high AD lens being put in the non-dominant eye. So with ECP swapping them around to BHVI Edof lenses. So if we ignore the sills in this case, the BHVI guidance would be 050 high, 050 mid, which is not the same at all what they're wearing for multifocals. So this is a case where you do not pick out what the patient had before. Now, the ECP is still thinking in terms of multifocals, starting with 025, because that's what the patient had before. And although he's saying, right, okay, I understand what you're saying about having the high in the right eye, I'm not too sure about the left eye, I'm going to go with low. And this is the thinking when we talk to the ECP, what the thought process was when they're picking up the lenses. However, it turned out that the BHVI guidance was in fact a very good starting point. So they were having trouble with reading. We started them again on the guidance, and actually they found they could increase that to 075, and the patient is now wearing these as revenue packs. So this is how we troubleshooted this particular case. Now this is a different case where we're troubleshooting somebody who has a lot of detailed close work to do, but also likes to play powers for golf. And this is a case where the one set of contact lenses doesn't work optimally for every single situation. So this person really wanted to see very, very close for near, and he had equal dominance in the eyes. So in fact, would be the BHVI guidance here. The final revenue packs for work, for close work, were 175 and 125, which is very close to the guidance, but high in both eyes. So he really wanted to get that really good vision, very close to his face. But for golf, that was causing a bit of blur because it's not recommended having high in both eyes. And the patient decided he liked those powers, but having the low type, you still see the scorecard at arm's length, but could see perfectly for distance. So the main number of lenses he was actually wearing were these for most of them, say 80% of the time. And when he was playing golf, he had those. Now this is an interesting one, mainly because we were at the time not really thinking this was going to work at all. One, the patient had a 2-sil in the left eye, and 2, was a long time wearer of RGPs, badly fitting lenses, as you can see, and wanted to swap to soft. But the patient and the practitioner both decided to go straight into it. The first lenses were prescribed at -550 mid and -6 mid. Wore those successfully over a month, went back for a re-evaluation. The ECP upped the left eye a little bit, and the patient is still wearing this now very successfully. I haven't actually got the VAs on this, except I know it's around about 6.6 in both eyes, because it's still varying. It was still varying at the time from the demolding effects. But this shows that even with a higher sil, you can be very successful with that. And it's a very useful lens to use for remolding because the variable profile will take up slack when you're having the powers going up and down as the eye demolds. Now, this is an example of swapping from one type to another within the Edof type lenses. The patient was wearing the pinhole type, or started to wear them. The ECP had started them off and then decided to swap them halfway through fitting to BHVI Edof lenses. Now I'm showing this is all completely genuine, so it may look a little bit confusing, but basically the ECP decided to start off with these lenses, even though that wasn't particularly the guidance for this type of lens. Found he had to reduce the right power to 050. So when he went to Edof, the patient was wearing pinhole 050 right, 150 left. The guidance is this, but because he'd already started the patient on one type with that, he went straight to that with Edof, which is, again, what I'm advising you not to do. Always start again from first principles, learn what you're supposed to do, and work with that. So needless to say, starting off with the incorrect guidance lenses didn't work. What the patient ended up with was the guidance plus an extra 025, which is what we're finding with hypermetropes in the UK. The ECP did prescribe the high in the non-dominant eye. I'm not sure if that's because the practitioner bias. I would still have gone with it the other way around, but needless to say, the patient is quite happy with that. So the message to take from this, if you are swapping from one type to another, always start with the guidance of the lens type you're going to, not the one you're coming from. And my last case here is from an ECP myope herself. It's very fussy. This is what the spectacle correction is. This is the BHVI guidance. Again, it's between these two because you've got an 075 silver there. Now, this shows that despite what the guidance says, your patient preference may end up with something different. So you start at that point, and then because this patient is working in testing rooms under dim light, having to see rulers and things really close, you know optics, you know what the situation is, decided she'd go down lower for working in dim light and so on. And for distance, actually still didn't push that up very far. So still preferred it to be slightly down in the left eye. So the take-home message from these cases is always start with your guidance, always make sure you've got a proper best sphere adjusted to what the patient wants, and then adjust if the patient has specific requirements for driving or for near. So to summarize all of this, do not order what the patient's had before in terms of base powers. Start again with the proper guidance to get you, they're there to get you the best option as soon as possible. It's been extensively worked on this. Always check your best fit in a trial frame, not a phoropter. Always allow the lens to settle in a natural environment, and understand that patients take time to adapt to this. Listen to your patient, work with your patient, and if necessary, get two sets for different, or sets for different events, say sporting or driving or reading. Listen to your patient. Before I finish, I would now just like to talk a little bit about business opportunities that Edof can afford your contact lens practice. In fact, using Edof as a practice builder. One of the issues that everybody is faced with globally is that as patients reach the age of the late 30s, early 40s, they start to drop out of contact lens wear and move into spectacles. This graph that I'm showing you here has been shown in many publications and shows the stark truth that as people hit presbyopic age, contact lens wear starts to drop off, and correspondingly and equally, spectacle wear starts to increase. This is due to many reasons, some because of the perception that presbyopic correction is difficult to do successfully on the behalf of ECPs, and sometimes the fact that it's easier for patients just to wear a pair of spectacles rather than mess around with glasses, overreaders, monovision, multifocals, and so on. But in fact, this is a missed opportunity and is an untapped need, because people will always need spectacles, whether they wear contact lenses or not. So they're going to buy spectacles in a way. The business opportunity here is to also supply them with contact lenses, Because really, if you don't catch them at this early age, once they're out of lenses, they rarely go back. They change their lifestyle to accommodate their change in visual function. So what are the opportunities with Edof? Well, because it provides minimal disturbance of vision and works really well with low myopes and emmetropes, because it doesn't really cause blurring in the distance in the low, it's very easy to put these patients in these lenses without them really noticing anything. You're not compromising their vision in terms of simultaneous vision with a multifocal. You're not compromising their depth perception or stereopsis with monovision. You're giving them enhanced vision when their vision is really only just starting to feel uncomfortable. As Edof also does not give the same effect of ghosting, it's accepted much more easily than multifocal options. Once you've got the patient over that psychological barrier of getting older, and let's face it, we all do that, you know, when you hit that age where you start to need reading glasses, it's a horrible shock and reminder you are actually aging. Psychologically, you don't even have to tell the patient it's a presbyopic correction because it's just superior optics. Once they're in that, they're wearing them, you've got them used to using their contact lenses to be able to see, and going back to glasses or spectacles is a more uncomfortable visual environment. You've then got hold of them and be able to set them onto the path of presbyopic contact lens wear for the rest of their life. So basically, this Edof type lenses are a really good opportunity to capture the patients at that point in time when they're likely to drop out, and overall will increase the percentage of patients wearing contact lenses, so you can sell them contact lenses as well as spectacles. So with that thought in mind, I'll leave you now, and thank you very much for inviting me to talk at this symposium. Thank you.